Good evening. This presentation on cultural competence for the deaf and hard of hearing is presented by Matt Cornwell and Melissa Fernandez. In this module today, we are going to identify what cultural competence is, delineate between deafness and hearing loss, discuss characteristics of what a healthcare disparity is and how they affect the deaf culture. We will discuss implications for healthcare professionals when dealing with the deaf population, then further focus on anesthetic implications. We will identify necessary components of creating a plan for deaf individuals that arrive to your healthcare facility, and in conclusion, we will present a case study that will provide a real-world example of a deaf person that arrives for surgery. So what is cultural competence? Cultural competence is the ability to understand, interact, and communicate with people across cultures. It is a developmental process that evolves over an extended period of time. In order to be culturally competent, one must be aware of one's own worldviews, yet respect the views of others, develop positive attitudes towards cultural differences, gain knowledge about the dynamics of other cultures, value and adapt to diversity, and be able to self-assess one's own cultural behavior in order to understand another's. A large part of successfully interacting with individuals from the deaf community is familiarity with how they became deaf and some cultural aspects that set this population apart from the rest of the hearing world. Deaf culture has its own set of rules and behaviors that hearing people may not understand. For example, it is impolite not to maintain eye contact when speaking to a deaf person. Maintaining eye contact means directly looking into their eyes. It does not mean looking at the person's face, looking past the person at what is behind them, or at the interpreter. These are considered distracting. There are different rules for concerning physical contact, touching, and pointing in deaf culture. For the deaf, touching someone's arm before taking your turn to speak is a way of indicating that you're about to say something. It is a floor-gaining tactic and is considered appropriate. When multiple hearing people and a deaf person are involved in a conversation and the hearing people talk fast, the deaf person thinks they are being rude and they feel as if they are excluded from the conversation because they can't follow the multiple changes in the conversation. Environmental sounds that evoke a response, like a knock on the door or a loud noise like a gunshot or fireworks, should be conveyed to a deaf person. Abrupt changes in conversation topics and long goodbyes are commonplace. Deaf patients also tend to rely on storytelling and more animated facial expressions when conveying information. In the deaf community, time is slowed down when compared to the hearing culture, and the medical model of fast and efficient care will likely frustrate both providers and the deaf individual. Thus, healthcare providers need to allow for the deaf to convey their symptoms in a slower, more natural manner that will lead to improved treatment outcomes and treatment adherence. A large part of deaf cultural competency for the healthcare provider is including asking the patient about their preferred communication approach and also making appropriate efforts to adhere to this preference and how the healthcare provider will communicate with them. So what is the difference between being deaf and having hearing loss? Being deaf consists of a sensorineural congenital absence of hearing in which there is a defect in the inner ear, cochlea, and/or auditory nerve. More than a 90 decibel hearing loss is considered profoundly deaf. Being deaf may be present at birth or acquired soon after, and may be from hereditary or non-hereditary causes, although more than 50% are from hereditary factors. Certain conditions increase the probability of obtaining sensorineural hearing loss, such as lack of oxygen to the baby at birth, maternal teratogens such as alcohol, tobacco, and drug abuse, severe jaundice of the infant, maternal rubella, premature birth, any form of traumatic delivery, or hereditary congenital hearing malfunctions. In contrast, hearing loss may be acquired and leads to mild, moderate, or severe hearing loss. Anyone with any degree of hearing loss can use the term hard of hearing. In fact, 11 million Americans have significant hearing loss, and a third of the elderly population will experience some degree of hearing loss, and it is often progressive throughout the remainder of their life. Acquired hearing loss can be due to prolonged exposure to loud noises, the aging process known as presbycusis, ototoxic medications, Meniere's disease, autoimmune processes, systemic diseases such as syphilis, diseases affecting the collagen in the ear, diabetes, and Paget's disease. In research, it is shown that approximately 2 to 3 out of every 1,000 babies are born deaf in the United States, and of those children, 90% are born to 2 fully hearing parents. These hearing parents typically have little knowledge about deaf culture, and their children may be educated orally and even prevented from learning a sign language until they discover deaf culture later in life. What are the differences between somebody who is deaf and somebody who identifies as a deaf person? Individuals that become deaf due to acquired hearing loss later in life may never choose to associate themselves with deaf culture and prefer to be titled an individual who is deaf. In contrast, individuals that are prelingually deaf most often associate themselves with deaf culture with a capital D and prefer to be titled a deaf person, as saying that they are a person who is deaf is considered derogatory, as it refers to deafness as a malady or condition that needs to be cured. The deaf culture understands deafness quite differently. They see it as a cultural and linguistic identity. Like any culture, deaf culture is diverse, layered, and sometimes divided and contentious. An individual with acquired deafness who knows sign language may not be accepted in the community of deaf culture because of not having similar cultural values or beliefs. The common idiom some deaf use to describe this phenomenon is that they are not deaf enough. For simplicity's sake, the rest of this presentation will revolve around the capital D deaf culture, although the implications and recommendations for healthcare providers certainly apply to patients that are hard of hearing. Deafness crosses many identities, is associated with ethnicity and racialized groups, gender, age, and disability. Many individuals who are born deaf or become deaf later in life communicate primarily through a signed language. Their communication methods may include American Sign Language, which is always regionally inflected, signed English, contact signing or pigeon sign, a mode based on fingerspelling titled the Rochester method, cued speech, or a combination of oral methods and sign called total communication. Children who are born deaf often have cognitive developments that may be impaired due to communication and inadequate stimulatory input from their parents, especially if born to hearing parents. They often have a low literacy level and a lower level of comprehension of written and spoken English. Writing notes may or may not be an effective mode of communication, given that for many deaf people, American Sign Language is their native language, not spoken or even written English. Their exposure to written English may be limited to what they learn in school. Additionally, acquiring a spoken language, such as English, without the ability to hear requires intense study. When a deaf person graduates high school, their English reading comprehension is normally around a 4th grade reading level. But even when deaf individuals read and write easily, written notes cannot provide the kind of rich and complex communication that occurs in a spoken language. It has been shown that parents that expose their children to American Sign Language by the age of 3 enables the child to acquire and develop language at a rate similar to that of a hearing child. Individuals who are deaf and have limited spoken English proficiency present at a higher risk for health disparities. But what is a health disparity? A healthcare disparity is defined as a population of individuals who experience poorer healthcare outcomes based on differences and disadvantages than the rest of the population. Healthcare disparities are often described as unfair treatment or some form of dissimilarity or mistreatment in comparison to the rest of the population. Disparities are typically differences between groups or populations when analyzing health insurance coverage, access to health care, use of health care, and overall quality of care. They are not usually intentional and often go unnoticed by providers. In the United States, adults who have been deaf since birth or early childhood are less likely to have seen a physician than adults in the general population, and healthcare disparities can result in decreased access to preventative health services, decreased satisfaction with the quality of care, poor understanding of instructions and/or use of medications, longer hospital stays, and an increased risk of medication errors and misdiagnoses. Deaf sign language users experience severe health disparities, which could be decreased with the modification of some factors associated with health professionals' attitudes, knowledge, and behaviors. The Americans with Disabilities Act of 1990 was passed almost 20 years ago, yet deaf sign language users continue to experience inequities accessing health care, health information, health research, and health-related careers, which limits their ability to achieve optimal health for themselves, their families, and their communities. The healthcare provider who embraces a cultural safety framework aims to improve the health status and well-being of the individual, improve the delivery of health services, focuses on the differences among people who are being treated and accepts those differences, and finally understands the power of health services and how healthcare impacts individuals and families. Addressing language barriers improves adherence with some preventative services and may help prevent chronic diseases or improve patients' long-term outcomes through earlier detection. How do healthcare disparities present in the deaf community? U.S. disability law is meant to guarantee communication access, but deaf people's stories of healthcare experiences indicate that they may still encounter barriers to effective access. To compound matters further, data on the health of deaf persons is lacking. In the United States, telephone surveys exclude deaf people, and questionnaires distributed by mail often use written English, which is a second language for many American Sign Language users. Written and spoken English surveys may also be inadequate because many deaf individuals have low English literacy and ASL is not grammatically the same as English. An example of how miscommunication can happen is if a doctor says or writes that a deaf person may need surgery, the deaf person might think that he or she needs surgery in the month of May. The sparse health data that does reflect deaf culture shows that adults report poorer health than adults in the general U.S. population. They often describe that they have to negotiate communication with healthcare professionals via facial expressions and writing, which creates anxiety and stress for the patient. They also claim that they do not trust their doctor's diagnosis, which leads to a lack of compliance. In addition, they also lack the knowledge and understanding on how to seek healthcare specialists. The deaf community is 25% less likely to be covered by private insurances, and they describe multiple times difficulty in coordinating an interpreter with doctors' offices and appointments, which often delays their care. Obstacles in communication with healthcare professionals leads to difficulty in describing symptoms, pain, a complete medical history, misdiagnoses, a decreased health and well-being, earlier death, frequent ER visits because they feel that the ER has better access than primary physicians, higher rates of chronic illness and disease, and readmission. They lead to increased length of hospital stay, unnecessary diagnostic tests, and low compliance with prescription medications, treatments, and appointments, worsening their condition. A few more facts about deaf culture and healthcare disparities are that communication about self-care and human sexuality is limited. The deaf and hard of hearing population is believed to have a higher rate of HIV infection than hearing people. The incidence of sexually transmitted infections and alcohol and substance abuse are also proportionally higher. It is estimated that more than 50,000 students who cannot hear speech, even with hearing aids, are enrolled in mainstream schools. Many deaf people are never taught about human sexuality and therefore cannot understand how HIV is transmitted. How does this happen? Communication styles between schools' limited resources for the deaf and hard of hearing lead to ineffective learning. An example of ineffective learning about self-care would be where a hearing adult may explain to their hearing child, brush your teeth or you may get cavities. The deaf child may be told by his or her hearing parent, simply brush your teeth. The instruction may be provided, but they lack the reasoning as to why they are completing the task. The same goes for explanations of human sexuality, STIs, and substance abuse. They may be taught what human sexuality is, but not how to prevent infections. Deaf people in most states receive substandard mental health care, worse than any other disability group. Studies show that 40% of the deaf population suffers from mental illness, while only 25% of the population of hearing individuals is mentally ill. Most deaf patients with mental illnesses are misdiagnosed with depression without a depression screening due to lack of communication between the patient and the provider. A recurring theme amongst the deaf community is when they see a physician about depression, it is assumed that they are depressed about being deaf, not that they are a deaf person who also happens to be depressed due to other life situations. Researchers state that physicians often do not hire interpreters, and hospital staff members do not know how to arrange interpreting services or how to ensure that an interpreter is qualified. When describing their interactions with providers, they mention it is meaningless. They express providers are two-faced and impatient, and when describing their overall healthcare experiences, they feel frustration, anger, sadness, fear, anxiety, and stress.
Feelings and emotions. Emotional impacts are due to lack of trust, misperceptions, fear of being misunderstood, fear of being misdiagnosed, fear of the unknown, fear of miscommunication, fear of not understanding a procedure, and a phenomenon they refer to as letting go. Letting go refers to choosing not to seek medical care for an illness or injury that is not serious, particularly when the work of communication or attempting to arrange for an interpreter outweighs the pain, discomfort, anxiety of the actual malady. A huge lack of trust for healthcare providers exists in the deaf community. Studies have shown that these patients often do not understand their diagnosis or their medication directions. They take wrong dosages, and they've even woken up from surgery after a C section finding that their tubes are tied when they actually wanted more kids just because they didn't understand the consent that they signed. Providers should always check for understanding, especially when giving such critical information. The deaf population feels as if the medical community views them as if they have an illness that needs to be cured. They also feel as if the medical community treats them like children. Deaf people face difficulties in their communication with physicians and are generally less health literate than people without hearing loss, which also impacts the reading and writing instructions. Remember that these adults have never even heard their parents speaking about their health history or any kind of medical terminology in front of them. Therefore, when they face healthcare providers, they demonstrate an immense amount of fear. Developing a plan. When developing a plan, demonstrate empathy, kindness, and thoughtfulness. Advocate for your patients. Be a calm, gentle, and patient provider. Face the patient when communicating with them. Place a sign of hearing status over the head of the bed. Label the patient's wristband with a universal hearing loss sticker. Make sure to provide the patient visual alerts, a caption phone, and TV captions. Accommodate your care to fit the needs of the patient. Know that they require more time, patience, and attention. No lip reading. Even the best lip readers have a 20 to 30% comprehension level of information. Understand that lip reading is not ASL, English writing is not ASL, and most importantly, educate yourself. In order to develop a plan, first we must understand these patients. Understand that they are often not trying to be rude by their gestures, they're just trying to communicate. Understand that English is not ASL, written English is not ASL. English is actually foreign to them. ASL is the sixth most commonly used language in this country and is not related to English. It is used by those in the Northern Hemisphere and it's a mix of native signs and French Sign Language. A deaf adult's knowledge of English medical terminology is similar to that of a non English speaking immigrant. When a deaf adult graduates from high school, they average at about a fourth grade reading level. Yet, we're providing them with discharge instructions to read, which is rated at approximately an 8th grade reading level. As providers, we must know that we cannot provide them with a written piece of paper. Remember, they have a lower literacy level because they did not develop their full cognition due to the lack of sensory neural stimulation as a child. Therefore, it is essential that we educate ourselves. Many deaf people lack world knowledge because of linguistic inaccessibility and cognitive defects caused by missing language during the critical language learning period of their childhood. Education is key. Implementation suggestions. The availability of preoperative anesthetic implications. During your preoperative assessment, take note that capacity to perceive spoke words is limited. Develop a tailored anesthetic plan to your patient by finding the cause of deafness. Is it a syndrome or a complex? Look for facial features, neck appearance, etc. Assess the level of education and ability to cooperate by using gestures and facial expressions. If communication does not seem feasible, utilize an interpreter. Do not sign any consent without an interpreter. Make sure all questions are answered before surgical masks are put on. Open-ended questions that cannot be answered with a yes or no should be used to check for understanding. Next, if possible, intravenous lines should not be inserted into the hands so that the deaf person can continue to sign. Lastly, the less preoperative sedation, the better. Intra and post-operative anesthetic implications. General anesthesia is a preferred method for patients that are hard of hearing. But again, the less sedation, the better. Use smaller doses of local anesthetic with neuroaxial anesthesia because high spinal block and signs of toxicity are frequently missed due to the deaf patient's inability to communicate. In addition, when utilizing neuroaxial techniques, watch the needle design used and the needle gauge, as a gauge wider than 25 has been associated with perioperative hearing loss. Also, consider BIS monitoring intraoperatively to titrate depth of anesthesia. It may be useful in recovery of patients as well because of oversedation, because it can further diminish their communication of pain, shortness of breath, or etc. Also, watch for autotoxic medications. When prescribing a medication, ask if it affects the hearing, the balance, or tinnitus. Keep in mind that more than 130 drugs in the clinical use setting can cause temporary or permanent damage to hearing. Next, watch the nitrous oxide use. Nitrous oxide causes oscillation of the middle ear pressures that could result in tympanic perforation and cause hearing loss. Extubate while the patient is awake. Prolonged intubation in the ICU leads to middle ear effusion and infection. Once the patient is stable, family members should be allowed to spend more time with the patient. Lastly, but most importantly, early detection of signs and symptoms of decompensation is key in these patients. Early detection of pain is also crucial. Pain is especially detrimental in these patients due to their inability to communicate or complain. When assessing the location of pain, sign the area of the body where the pain is occurring. Case study for cardiothoracic surgery. A 45-year-old deaf patient of low socioeconomic strata is admitted with a history of easy fatigability and breathlessness on less than ordinary activities. He is found to have severe mitral stenosis, an enlarged left atrium with a clot in the left atrial appendage, and moderate aortic regurgitation with atrial fibrillation. He is scheduled for a double valve replacement. What considerations do you have for him and his family on the day of surgery? Upon a thorough preoperative evaluation, you determine that the parents of the patient are healthy with no hearing or speech defect and have 5 children, 3 sons and 2 daughters. Among them, 2 sons and 1 daughter are deaf congenitally, while the rest have normal hearing and speech functions. The patient's wife and son have normal hearing and speech functions. Remember, knowledge of cardiovascular disease among deaf people is low as compared to the normal hearing population. Preoperative assessment of the patient's expressing capabilities, educational background, and basic understanding ability can help in deciding the required level of preoperative training. Appointment of a sign language or communication specialist can help in establishing an effective communication between the patient and the healthcare provider. The patient is explained about the surgical procedure and anticipated postoperative course and taught to express pain by showing the visual analog scale. During your preoperative assessment, since the patient is unable to convey problems, clinical and objective assessment should be given prime importance. Intraoperatively, after all masks are put on, the interpreter follows with the patient into the OR to translate until the patient is induced and intubated. Postoperatively, some facilities have a general rule that open heart patients are transferred to the ICU restrained in order to avoid inadvertent extubation. If this is your facility's policy to restrain patients until they are fully awake and extubated, this can definitely not happen with a deaf patient, as this is their only means of communication. Vigilance and a provider at the bedside is the only humane and safe way to provide care for this patient. Additional postoperative considerations are to extubate early and with the patient awake. Once the patient is stable in the CVICU, family members should be allowed to spend more time with the patient. Minimize sedatives and hypnotic administrations in the postoperative period to actively involve patients in rehabilitation. Early removal of catheters and tubing and early mobilization should be encouraged to prevent postoperative psychosis. Objective assessment of pain and effective pain management and pain control should be instituted. Properly trained nurses and paramedical staff should be engaged in the care of these patients. Remember, understanding that these patients are a cultural minority of their own allows us healthcare providers to provide optimal care for these patients.